So first of all, you need to know that I'm not an expert, and I've made mistakes. Anybody else here made mistakes in working with people? Thank you, I'm in the right room then. Because anybody who gets up here and says, I've got it all figured out, they are not telling the truth. So first of all, I am blessed with an incredible staff who writes really wonderful articles and very practical information. We have a full catalog of visual supports, so use us. And if you want to link us to other sites, please do so. You know, our only goal is to really help others who are in the same work that we're doing. So let me tell you a little bit about the realities of my work. I've been doing this for a long time. And when I first got involved in the area of autism, the incidence was 1 in 10,000. And now, according to the Centers for Disease Control, it's 1 in 59. In our state, it's 1 in 68. So we've got more kids. It used to be that when I would tell people what I did, they would ask, what is that? And now when as I was flying here, as a matter of fact, I had somebody sitting next to me who pulled out a book on autism, and that's not unusual, as you know, to know somebody personally that is on the spectrum. The other thing that we're seeing in our state, and I don't know if this is the reality in Alabama as well, but we're seeing children who are coming to us with a lot of different disabilities. So probably the record is I was working with a child who had 14 different disability labels: oppositional defiant disorder, conduct disorder, ADHD, and the list goes on, and then autism spectrum disorders. And so when we got interested in the area of mental health, because what happened in our state was that when a child had a co-occurring ASD and mental health issues, the community mental health centers wouldn't see them. And so parents had, the only choices for them were either to take their child to the emergency room or call the police. And so we started trying to address that in our work with mental health as well, and I'll talk a little bit about that at the end. The other thing is the reality for us in Indiana is that we have an opioid crisis. You know, we have parents who are living in poverty and children who are living in poverty. We have children who have parents who are in the criminal justice system, who have parents who have drug issues themselves. So, you know, more kids with more complex issues, living more complicated lives, and the reality of it is that there's not any easy answer. Is that a reality for you all too? So, you know, some of the solutions that we used to use just simply are not working anymore. So, and just so you know, I spent a lot of time in schools with students. I spent a lot of time interacting with parents. And I am learning all the time from these children who seem to change as I progress in the field. So I get called in, being a board certified behavior analyst, I get called in a lot on behavior. And as a teacher, I worked with students who had behavior issues. And so we look at categories of behavior, and these are categories. These are not operational definitions. Within these categories, you want to do operational definitions. For example, you know, I'll get called in, people will say, we've got this child who's non-compliant. I don't know what that means. I think I've got it, but I don't know what that means, you know? And so we have to really operationally define these. So we have children who have behavioral deficits, and those are children who are withdrawn, who refuse to do work, who put their heads down on the desk, who are quiet, who are alone. And then we have children who do behavior excesses, and those are children who do things like self-injurious behaviors, property destruction, and aggression. So everything in between. So I will get phone calls from all over the state of Indiana that say, what do we do when? What do we do when a child is hitting? What do we do when a child is biting? What do we do when a child is kicking? And I will tell you, I don't know. I don't know. And the reason that I don't know is that behavior does not happen in isolation. The behavior is not all within the child. We are part of that dance, and we have to assess what we bring to that dance as well. And the context is very different. You know, I'm sure that you find that how students behave on a weekend of partying is very different than hopefully they'll behave during graduation. We are all driven by context, how you guys are behaving right now. And so, but I do know that when people ask me that question, they're probably in crisis. And so I have to respond to that crisis with a response that will hopefully keep everybody safe and keep the child safe. And my goal is always to de-escalate the behavior and to look at strategies to calm everybody in the environment. Because oftentimes what happens is that when a child is becoming aggressive, everybody's getting more excited. And the more excited we get, what happens with our kids? They get more excited, you know. And I tell folks that when I'm dealing with behaviors, I go into a happy place in my head. I don't show any emotion, because the moment you show emotion, they've got you hooked. I used to tell people that my happy place was on an island with Johnny Depp, but he's gotten kind of weird, so I have to find a different happy place. So, but I just think about, I give them suggestions about what to do in the heat of the moment. I will also tell you that within a few minutes, I can tell what people's values are about children. I've walked into classrooms before, and I've had teachers say to me, I really don't like this kid. Can you get them out of my class? Or how am I going to control this child? And our job should not be about control. It should be about teaching children skills, building their skills, teaching them to respond in a different way. So, and I think that this is a really, what I see in our state is an evolution, and over again, as I go into schools, as I work with educators, I hear them saying, the strategies that we used to use aren't working any longer, And so we're really talking about, as we understand the neurology of behavior and such, we're really talking about individuals, supporting individuals to learn different ways. So I think this is something that we all have to assess, is what are the values that we bring to the table as we're working with children. So when we get phone calls about behavior, we try to figure out what's going on. Is it due to lack of training? Is it due to limited resources? Is it due to classroom management issues? What is it exactly due to? So we try to figure out what's going on. And in special education, we have this process called functional behavioral assessment. And functional behavioral assessment, this is the definition. Functional behavioral assessment is not a form you fill out or data that you collect. It is a process of discovery, okay? And it may require a lot of tools. I liken it to a medical exam. I have inherited a 91-year-old Greek mother who is feisty and is amazing. And but about 10 years ago, she started losing weight. She started having sweats at night. She started having chronic headaches and diarrhea. Went to one doctor and said, we're going to treat your headaches. Went to another doctor and said, you need to drink and sure to gain some weight. Went to another doctor and said, we need to treat this, this, and this. Finally went to a doctor who said, we need to find out what's going on. We need to find out the underlying cause. And they ran tests on her and found that she had lymphoma. Well, the lymphoma was all contained in her spleen, had her spleen removed. Last summer she went to Greece and she climbed around the mountains like a mountain goat. She has seen the wedding of 2, soon to be 3 grandchildren, and has seen the birth of 4 great-grandchildren. So, but too often when people come to me and say, we have a child who is hitting, that is a symptom. And you can treat the symptom, but if you don't treat the underlying cause, other symptoms will occur. So we've got to dig deep and try to figure out what that underlying cause is. Because there is not a recipe that says child does this, do this, and shake 3 times and the behavior will go away. So once the behavior is determined and you have operationally defined that behavior, whatever it may be, then it's really a process of identifying antecedents and consequences. And so there are 2 different kinds of antecedents that we look at, slow triggers and fast triggers. So in my mind, the setting events are the most important triggers that we look at. And setting events has nothing to do with the room that they're in. It is not in the lobby, in the classroom, in the hallway. It's not about that. It's about, have you ever had one of those mornings where you get up and every outfit you want to wear is dirty? And you go to get a cup of coffee and there's no more coffee in the house. And then you go into your car and the gas tank is almost on empty. And then if you're like me, you're looking at the manual to see how many miles do I really have left in order to get to work. And everything goes wrong in the morning. When you get to work, somebody may ask you a question and you may give a very irritated response. And it's not because of the question that they've asked, it's just because of everything that's happened before you went to work. I actually tell my staff if I've had a bad morning, just to prepare them so they don't ask me things that are going to require money or my time or, I don't know, me to do something different. So, but understand that these are things that may or may not happen in the context of the school or the classroom, but they can increase the likelihood that a behavior is going to occur. So for us working with children on the autism spectrum, anxiety is a major one. Lots of our folks have anxiety. And with anxiety goes depression. So understanding if they really have anxiety going on. I also look at biological issues because I will see kids who have not great diets. Some of the questions I ask parents when I first start talking to them about their child is, talk to me a little bit about your child's eating habits, about their sleeping patterns, talk to me about their toileting habits, their bowel movements, to try to figure out if there's something biological going on in their system that is contributing to the behaviors as well? Do they have seizures? I think we have to dig deep and find out what's going on with the behavior. Years ago, I was working with a young man who had pulled his adult teeth out. And people kept saying he's just doing that because he has autism and it's just a behavior. Well, he wasn't doing that. We finally got somebody to look at him seriously, scoped him, and found out that he had major ulcers. And once we dealt with the ulcers, we saw the behaviors go away. So you have to look, kind of dig about that. I look to see if there's kids who are in trauma. And I'm going to give you a case study later on about a child who I've worked with who had a lot of trauma going on. And we have to realize that having that trauma going on in their life is going to set them up for having more difficulties, and understand a little bit about the neurology of kids. I look at schedule changes. In Indiana, we have this thing called snow. And so we may have snow days. We haven't had as many this year. And so if there's schedule changes for our students, that throws them off a little bit. So our schools actually create snow day calendars for kids, or schedules, so they understand. Staff changes can be one for our students. And I was working last year in a school that they had 5 different teachers over the course of a year. Actually, one day I showed up and they had no teacher, so I got to be the teacher for the day. And so for those kids, lots of inconsistencies, and I think one of the things that I see adult providers dealing with is the turnover of staffing and how that creates such havoc for the folks we deal with. Medications that are changed or missed, and we know that there is not necessarily a pill that deals with all the characteristics associated with autism, and we have a hard time finding psychiatrists in our state, although it's starting to get easier, who know how to medicate individuals who are on the autism spectrum. Irregular sleep patterns, illness or impending illness. So often as a teacher, I would have a student who would have a behavior incident and then they would get sick. And that was their signal to me that they were getting ill. Missed meals, so I will make sure that I get you out of here at 12, especially if you've had a bad morning. So, and arguments or fights with parents, classmates, teachers can all be setting events. Skill deficits. Skill deficits are the most important thing. And so I live by the credo of Ross Greene. And if you haven't read his work, he's really brilliant. And Ross Greene says, if they knew better, they would do better. And we've brought him into the state several times and has been part of the shifting paradigm for us in the state of Indiana as well. And then I look at home conditions. Now, I was told one time, I was at a conference one time, and a very well-known behaviorist said to an audience of special ed directors, children are not impacted by their home life. Are you buying that? Because I'm impacted by my home life. And you guys are lucky because I'm good right now, okay? And so home conditions impact folks. And what's interesting is that when you start working in the area of mental health, what you'll find is that there is something in kids who live in chaos where they feel more comfort in that chaos. Okay? So understanding that as well. Past or current experiences with school. Some children have not had good experiences with school that cause them to have some trauma about school and resistance to be in schools. So all of these things can be setting events for our children. So, and then fast triggers are things that we know if this happens that the behavior is likely to occur. We know that if a fire drill goes off, that the behavior is likely to occur. We know if the child sits next to a certain student, they're likely to have a behavior. We know if the child is with a certain staff member that they're likely to have a behavior. We know that if a child is asked to do a paper and pencil activity, that they're likely to have a behavior. So there are things that we know can predict that a behavior is likely to occur. Unstructured time is a big one for our folks. Certain wording. As a teacher, I had a student who hated the word no. And I had to desensitize her to the word no, but if she heard the word no, I just had to prepare for things to just break loose with her. Transitions are another one that we will see with our folks as well. So there's a lot of things that will will be triggers for our students, and they differ for each child. So consequence. In schools, we talk a lot about consequences. And we talk about it in terms of kind of a more punitive approach. This child has to have consequences. And that's one of the things that when I hear somebody say, but what are the consequences going to be with this child? That's a value that I have to work against. So in behavioral world, the only definition, and for the BCBAs in the audience, tell me if I get this wrong, the only definition of consequence is that it comes after behavior, antecedent behavior consequence. The only definition of reinforcement is that it increases a behavior. The only definition of punishment is that it decreases a behavior. So how many of you are reinforced by chocolate? Come on, I need to see some hands. Okay. So I have a colleague who hates chocolate. And I'm not really sure she's an American. I have my questions about it. So she had done something nice for me, and I took her chocolate, and she said, this isn't going to cut it, Cathy. You know. On the other hand, how many of you believe that for students in schools, suspension and expulsion is actually a reinforcer? Yeah. I mean, I love it when I go into school and the principal goes, yeah, we had to expel this child for the last 2 days, and the child comes up and says, look at the new coat I got this week with my mom, or the haircut that I got. So you know, if you look at the data in schools, it's often the same children who are being sent home. You know, I mean, there's days where I could like to figure out how I could be sent home. And if I could figure out that behavior, I would do it repeatedly, you know? And so, you know, when you see a child who is the repeat offender, that is not working for them. So you have to understand is what is the payoff, what's maintaining the behavior, because we continue to do behavior because it gets us something or it gets us out of something. So we've got to be able to look at that in a very objective way. So there's all different kinds of tools and instruments. There's, you know, interviews and rating scales. I sometimes will do learning styles inventory. I've worked with several children and actually just had an email about another child today who seem to have some good adaptive behaviors and good communication skills, and so they're perceived as having higher academic skills than they really have. And so then they're put into academic work that is really above them, and then they start acting out. This kid is running out of the classroom, and you know, as I asked the question, is the curriculum too hard for him? The response was, yes, it is. So he has learned when I'm put in a situation where I'm going to fail, because I think kids want to succeed. I have to believe that. That's my belief system. That if he's put in a situation where he's going to fail, he leaves the situation, he runs away. So we're going to have to make sure that we're really teaching kids the way that they learn, and that we really understand and really look at that comprehensive evaluation to see where they are academically, socially, behaviorally, really understand the child and the whole child, not just pieces and parts of the child, but the entire child. We also, do you all know what the ACEs is? The Adverse Childhood Experience Scale. It's used a lot to determine indicators of trauma. I will use that with some of our kids. And to understand what that child's life is. And I think one of the things that has resonated with my staff, and both in the autism work and with our mental health work, is that we've got to look at the whole child and their whole life. And not just at the child that we see in that moment, but we have to look at the whole child and what's going on in their life. I use the Lagging Skills Inventory, which is a tool that was developed by Ross Green that gets us to look at what are the skill deficits for children. And I really love his work. I also, in Ziggurat, which was developed by Barry Grossman and Ruth Aspey, it's a format for kind of evaluating children. One of the pieces that I love out of it is the Strengths and Skills Inventory. Because I used to feel so badly. I'd be in these meetings and we're talking about how bad this child is, and they do all these behaviors and they're rotten kids, and you know, I'm getting to hear and I could see the parents just aching as they're listening to this. And so one of the things that I love about this, I will give this to parents and I will give this to educators to fill out before the meetings so that we can start identifying what are the things that the child does well, what are their strengths, what are their interests, so that we can kind of turn the conversation. And then we will begin the conversation with a discussion of this tool as well. And then I do a lot of record reviews. And I will tell you as a behaviorist, and again, you know, some of you may disagree with this, the thing that is least helpful for me are the reams and reams and reams of narratives that people write. It tells me about how frustrated they are, and it may be necessary, but it's not oftentimes a good use of our time. We could do it with less of a narrative. And it doesn't give me that really objective information. And I think the tool is that when you're looking at behavior, you have to remove judgment as much as you can. And those paragraphs are filled with judgments. So the questions that I use, you know, there's a lot of questions. And, you know, when did the behavior first happen? How long has it persisted? What's been tried? What's worked? What's not worked? But the question that I ask over and over again is, tell me under what conditions the individual does really well. When they're being really successful, what's happening? And because if I can understand those and I can start replicating those, then I can start putting together a behavior plan. You know, when is the individual most successful? What are their strengths? What are their interests? and we really have to get away from this deficit model of only focusing on deficits. You're building your career based on strengths, yet when we deal with people with disabilities, we try to focus on deficits. And we really have to turn that and focus on strengths much more with our individuals. And one of the questions that is part of our behavior plan is I will ask people to tell me when during the day will an individual feel successful. Because I think all of us need to feel successful, and some of our folks have never felt successful. So we need to make sure that at some point during the day, and by the way, you may be sitting there thinking, yeah, but she's never worked with folks as tough as I'm working with. I've worked with a lot of really tough folks. One of my students, who was one of the toughest, would go between 400 and 500 pounds. He had ripped the door off of a refrigerator. He had hoisted an old-fashioned TV in the cabinet at a worker in the home. He would hit himself in the head hundreds and hundreds of times a week, so much so that he was causing himself to have some changes in his scalp and in his neurology. He was one of those guys that when I would try to stop the hitting, he would, even though he would keep his nails short, could take skin out of my hand. I still have scars to this day, And he was nonverbal. He had a lot of things going on. We were able to, by looking at the behavior and looking at what was causing it, which we realized that they were using restraint on him, and restraint for him was pleasurable. So he was doing the behavior to be restrained, which was pleasurable for him. By building in deep pressure proactively, we were able to reduce his self-injurious behaviors from over 400 a week to 11 with less intensity, and over the course of a year. And just so you know, I've never done this stuff on myself. I really believe in the team approach. It has to be very collaborative. So then we do direct methods, and direct methods means that you're actually looking at the individual. So we do frequency, recording, duration, look how long the behavior is lasting. One of the tools that I love is the scatter plot, and it is just my tool of choice. And what I love about it is that anybody can do it, and it's a very quick way to get a visual of a behavior. So usually people guess that on day 3 that the child was absent. On day 3 the math teacher was absent, and so see how he set the context for the entire day. He was the setting event for that child's day. So we collect data, and then sometimes my folks in Indiana will add things to put an intensity in here as well, so that we're not only looking at frequency, but we're also looking at intensity, and we can also key it to look at duration as well. So, everyone has their tricks and tools. One of them that I use is this. And for me, I sit around a table and people kvetch about the behavior, and talk a lot about it and how awful it is. And so I try to put it into a framework so that I can take that information and move it over into a behavior plan. So for me, this is just a framework that I use. I know there's a lot of other frameworks out there. You're welcome to steal this and use it as you want to. So this was a child who would pinch, yell, scream, elope, not run off and get married, but he would run. He would refuse, he would kick, he would hit, and then they said, but you have to put down aggression because he's just aggressive, okay? His setting events were that he had autism and anxiety, he had seizures, he was on medications, he had a lot of allergies, he had communication limitations, he had sensory challenges, he lacked self-regulation and self-management, and he had poor social skills. So the triggering antecedents for him were certain demands, too much talking by staff, transitions, leaving the school bus, changes in routines, certain academic work, too much paperwork, and being read to or lectured to. What he got out of it was that he was able to end an activity, he got access to a desired event or activity, and he got attention, and he got sensory. So here's what happened. We know that this young man does not like paper and pencil activities. He comes in off the bus, which we know is difficult for him, and the first thing the teacher says every morning is pull out your pencil and a piece of paper and put your name on the top of the paper. And then she proceeds to do paperwork, one after another, okay? He starts having aggressive behaviors and doing all this stuff. And what happens to them is that he's put in a timeout room that has a yoga ball in it that he can sit on and bounce on. There's a mirror in there's a window in the door, and his staff member, who he really likes, stands there and looks at him, and they kind of converse through the window. Who's in charge? He is. He has figured out a way to get out of doing work. He is getting access to something he wants. And the teacher says, I don't know why, but sooner and sooner in the morning he is having this behavior. Well, yeah, he doesn't want to do the paperwork. So then we have to talk about how we start the day in a way that is more appropriate for him. So this is the form that I put together, and I added on there that I talk about the strengths and skills as well, so that we understand a little bit about what we can do differently for the child. And then always, as part of the behavior plan, you've got to talk about what are the behaviors that you want to replace, and what do you want to replace them with. And when you choose a replacement behavior, you have to make sure that it is as efficient and as effective as the challenge behaviors. I've been working with a young man for years who has a very cool guy, and he is at the upper end of the spectrum, whatever that means. He still has challenges, but he will talk out in class. If the teacher takes a breath, he feels that's the opportunity for him to speak. So the behavior that she's dealing with is that he's talking all the time and interrupting her. And so I said, so what do you want him to do? She goes, well, I just want him to raise his hand. Okay. So we give him a visual. I talk to his peers about prompting him. I talk to him about it, do a social story. We talk a lot about it, and I model it for him, and I sit there and I coach him on it. And then the teacher calls me back and says, it's not working. So I said, okay, well, let me see why it's not working. So here's what I saw. He's sitting in the class and he's doing this. And he doesn't get called on. So he goes right to doing what? Calling out in class, okay? Because he has found that that is more efficient and effective than the alternative she was giving him, okay? So you have to give a lot of power to these alternative behaviors. So there's a lot of alternative behaviors that we focus on. And I don't have the time to go through all these, but let me just talk about one of them. Communication, which I think is critical for our folks. And we know that there's a very tight link between communication challenges and behavior. We also know that kids who have AAC devices in elementary school, by the time that they hit secondary, only about 10% of them are using their AAC devices. By the time they hit adult services, only about 10% of that 10% are using their AAC devices. Okay? We've got to give individuals a means to communication. And I tell parents that if I were the parent of a child on the autism spectrum and you told me that my child had speech 30 minutes a week, I'd be furious. If you told me that they had it 30 minutes twice a week, I would be livid. If they told me that they had it 30 minutes for 5 times a week, I would still be angry beyond belief. Because parents ask the wrong question. You ask the question, how many minutes of speech therapy services does my child get a week? You should be asking, how does my child communicate at all times? That's a very different question that requires a different answer. So that's a very fast overview of some of the work that I do. So let me tell you about a little guy that I have worked with. He was a guy that I walked into. He was 10 years old at the time. And I walked in, and he was kind of like Sheldon Cooper. Do you know what I mean? He had the hairdo, the blonde, and he had the voice. And he was standing at a board, and he's doing mathematical calculations that were way beyond me. And he was having some behavior issues. And so, and I walked in, and the teacher said to me, can you get him out of here? She says that in front of him, So I observed for a while, and I spent some time getting to know him, and I hung out with him. I found he was just delightful, I'm so blessed. These kids are just amazing children to get to know. And so I started asking questions of people about his life. Found out that his mother was in jail. He hadn't seen her for 2 years. Okay. Comment was made to me, he doesn't care that he doesn't see his mom. He has autism. Do you guys believe that? No. I'm going to give you 2 very important words that I don't want you to lose, no matter how many degrees you get. And these are the most important words that have carried me through my career. You ready? Common sense. Okay? Common sense tells me that when a child doesn't see their mother for 2 years, they're feeling it. The dad was a truck driver, loved his son, but dad wasn't around, so he went to live with an aunt who didn't like him very much, and so if he was sick at school, she wouldn't pick him up. He had to stay at school. And so he stayed at school with a teacher who didn't like him, and he had all kinds of behaviors. And so, but I could see that as I followed him around is that he was really kind with kids, that he wanted to help out. See, another value that I have is that I think kids want to help. I think people want to help, And so how do we put them in situations where they're going to help? And so Went to the meeting afterwards, and the principal's there, the psychologist is there, the teacher's there, parents didn't show up, and the special ed director is there, and they're going, okay, what is it that we need to, what is it we need to do to get him to understand that he can't act this way? And it was all focused on consequences. We've got to punish him this way, we have to do this to him, we have to take this away. And I just kept sitting there saying, he needs a champion. And then they would go back to the discussions about how they have to punish him and they have to do this punitive stuff. And then I would just say, and he needs a champion. And finally the director looked at me after I'd said it about 5 times, and they kept carrying on with their conversation. She looked at me and she goes, you know what, Cathy, I think he needs a champion. And I said, you know, that's a brilliant idea. Because it doesn't have to be my idea at all. So what we did is that we found actually a big brother to work with him, a teacher that had worked with him in a previous school he really liked. Because one of the key things that I know about children on the spectrum is that they do better for individuals who they have a rapport with. If you have a rapport with an individual, you can make such a difference in their life. And then we started doing yoga with him. He started leading his class in yoga because movement is an evidence-based practice. We know that if children have the opportunity to move, that it actually helps with their behavior. So, and he was really kind. He was in a class of many students who were not very coordinated, and he did not chastise them. He was not rule following with them. He was very kind and kind of helped them. And the other thing that we did with him is that he was allowed to work on math with some of the other students who didn't have his math skills. And we were able to turn his behavior around. And I got to see him last year, and he's doing fabulously. But people have to know his story and understand how we address it. So again, we have to look at the whole child. So realizing that there's a population of our folks who have mental health issues, we decided to start the Indiana School Mental Health Initiative. Because autism is not enough, so let's take on mental health as well. But for me, it was a real calling. And especially when I saw, you know, we have this false belief that there is, and I saw this with our state agencies who their funding is very siloed, and it's really hard to kind of get comprehensive programming going, and people have a very siloed mindset, and they believe that there was a strategy for people with Down syndrome, there's a strategy for people with autism, there's a strategy for people with mental illness, there's a strategy for a person with ADHD. And what we know at IRCA is that we go in through the door of autism, and that many of our schools adopt strategies school-wide, and they work for all kids. You know, how many of you are visual learners? You don't want people reading the letter to you, you want to read it yourself? Well, we have schools that have adopted our visual support school-wide, and they benefited all children. So the first thing is meeting with state people just to say, we've got to get rid of the stigma that there's a set of skills that we have to work on individual children with our categories of need in. So, you know, we saw the need, and as I met with people at the state, what I found is that we had surveyed the problem. You know, I would say, do you realize that there's a problem with individuals who have co-occurring mental illness and a developmental disabilities? Oh yeah, we've had a study group on that. Oh yeah, we've had a survey on that. Oh yeah, we've commissioned a summer study committee on that years ago. We had admired the problem to death and done nothing about it. And so I went to our state special ed and said, I don't know what you guys are doing about this, but here's what I'm seeing in schools. I need some help. And so they gave me a little bit of money, not a lot. And I was very fortunate. About that same time, we had a change in superintendents, and the woman who had headed up the mental health work with the old superintendent was released. And she was a social worker, and so she joined me. So we kind of are looking at both working with kids with disabilities, you know, so with behavior consultants and such, and then also looking at social emotional learning statewide. And we've been able to get the state to move on some social competencies. So one of the things that resonated with me, and in Indiana, we have autism consultants in our districts. We do not pay them, the district hires them, we support them. And so we have over 200 autism leaders in our state, and we meet with them about 5 times a year, 6 times a year. We have a listserv, we share information, and for me, they become incredible colleagues. We problem solve things together. So I had a director say to me, I wish that you would do for the behavior consultants what you did in the area of autism. So we have a behavior consultants listserv, and we meet with them. We'll be meeting with them next week, and I think next year we're going to take the approach of doing triages, so that we as a community are going to triage in different regions of the state problems so that we can learn how to problem solve. Again, we have really promoted social emotional learning. And you know, in our state, you know, the verbiage that we used is that we have tried everything to improve reading scores. We've changed curriculums. We've tested more and more and more. And we've changed the curriculum, and it hasn't really improved our reading scores. And so, and there is a lot of research out there. There's a report called A Nation at Risk. There's a lot of research out there that says that when children are socially, emotionally healthier, that they learn better. Okay, so that's where we've really landed on. The other thing that we did is that we really felt in those districts that were doing a really good job that they had a lead person in their district who had taken on the charge of mental health. And so we went back to our districts and said to them, will you give us the name of whoever is taking the lead of mental health in your district? And so what we see is now, and everybody gave us a name, but they gave us the name of a superintendent or a principal or a director of special ed, but they gave us a name. But now what we see is that districts are starting to hire a person who is the lead in the district to promote social emotional learning and mental health issues. We've developed 5 foundational documents and that we've passed around the state. We developed a website. At first we developed a website with Look Up Indiana, which is out of one of our foundations, because we have really wanted this to be a collaborative in the state. And really, this project has only gotten this far because we have a lot of people surrounding us. We have a statewide leadership group that has helped us all along the way. It's made up of superintendents, of directors of special ed, of community mental health center providers, of advocates. This has been really a movement of people joining arms and kind of seeing the need. So we have a website, and then we got very interested in. I started finding out about what IU was doing. Found out that one of my colleagues is on the board for Bring Change to Mind. Have any of you ever heard of this organization? It was started by Glenn Close, who has a sister and a nephew with mental health issues, and they do mental health clubs at universities. And so I just said to her, okay, we've got one at IU. Could we start doing it in high schools? And so in the last year, so we've teamed up with Bring Change to Mind, and we have started with, they only give you a certain number of clubs that you can start out, but we've started 10 high school clubs to really reduce the stigma of mental health. We had a parent, I was meeting with a group of people talking about policy, because we've also gotten into the policy world, and just had legislation passed yesterday that would give funding to schools to have mental health coaches and to really promote social emotional learning. So really incredible day for us. But so the Bring Change to Mind has really made a difference in our schools. We had a parent in one of the meetings who said, you know, my son was the star athlete, he was a straight A student, and he didn't know how to fail. He didn't know how to tell people that he was failing. And so he ended up taking his life. So she has really invested a lot of energy into this, and so we're really working hand in hand with a lot of other organizations to bring change to mind in our high schools, and our goal is to have 50 more high schools in the next 2 years who are part of this club. And Bring Change to Mind said that they will then come out and staff this and help support us to do this. We had a summit, and we had close to 500 people. We had never done this before, and so we had no idea who would show up. We had a waiting list of 300. And we asked school districts to come as teams, and community mental health centers who have relationships with schools to come with them. And we brought in national speakers and highlighted some of the good work that's going on in our state. Probably one of the highlights was a superintendent's panel, and then we gave them planning time to look at where they were. We gave them an implementation guide, and then we gave them planning time. We have paired up with the Center for School Mental Health to do something called the SHAPE assessment in our schools to determine mental health needs. And so the next step in this process is that we're looking at developing, we've done a lot of training in the state. and lots of regional conferences. We travel all over the state of Indiana. But the next thing that we're working on, and actually one of my staff members is meeting with somebody today to talk about doing a coaching model where we could actually go into the schools and coach on how to implement some of these strategies in the schools. The Center for School Mental Health does have a lot of information about evidence-based practices related to mental health issues as well. So that's what we're doing in Indiana. So thank you for the opportunity to talk to you guys.